welcome to our closing plenary. Please come on in and take a seat. My name is David Bashai. I'm the president of the International Health Economics Association. This will be our third plenary, and we really had a great week, or at least I did, and I know so many of you did, and it's time to really take a moment to express our gratitude to the local organizers. Could I have the local organizers from Basel please stand? Please stand so we can appreciate you. Basel, there they are. Stand up. Thank you so much. It's really been a phenomenal week, and we've had a great time, great food. Last night was exceptional, so I know it was a lot of hard work. The other part that we enjoyed was the scientific program, and I see some members of the scientific committee here. I see Denzel. I don't know if Joe is here. Could you please stand, please, Denzel and Joe, if you're here. Please, let's give them a round of applause. Thank you. Thanks so much. And if you reviewed abstracts for us for this round, please stand. All of our reviewers, please stand up so we can appreciate you. All of the reviewers, I know there's many of you here, please stand. Thank you so much. So I know who won't stand is Di McIntyre and the team for Managing Matters. I know they'll be embarrassed, so wherever they are, please, let's just give them a round of applause, but they work tirelessly. So it was a great week, and I and the rest of us, we come together for iHEA every 2 years. We meet our old friends, we make new friends, and we talk about what we love, which is health economics, what we do every day to create new knowledge about what it is that makes populations healthy, what it is that makes populations financially protected, what creates efficiency. Efficiency is our passion. That's why we came, and that's what we want to talk about. Our plenary 1 and plenary 2, it was very obvious what they had to tell us. They had to tell us that convergence theory is wrong, that if there is this common technology and optimizing decision makers around the world trying to do their best for health, there shouldn't be these geographical and time-based variations. Everybody should apply the best technology. We've created science about what it is that makes populations healthy, and yet there isn't convergence. At the same time, though, they told us stories. They did science, both Raj Chetty and Janet Curry, and all of us have done tremendous work to say this policy works, because we're economists, we say this caused a better outcome, this caused a better efficiency. So we have a repository of knowledge about what makes populations healthy, and yet we look at the maps of our world and we see variation in policy uptake. We don't bury our heads in the sand. Some do, but most of us don't. We say, how can I get my science used? How can I get the policymakers to do better? And I've been to Econ and the European Health Economics Association. At each time I see our regional meetings, at African Health Economics Association, our profession wants to know, it's not enough to show the knowledge and create the knowledge. How can we help it be utilized better? So other health economics associations have been putting together material to help us do better. What we thought we would do today is really go to stories. We know that narratives of how we actually tried and succeeded, how we tried and failed, really gives us something to copy and something to emulate. And so I'm very happy today to have that opportunity to share that with you. Before I introduce our speakers, I want to introduce you to what we'll be doing for the hour. First off, there is a website here that you can use, and I fully expect you to act like millennials and don't look at me, but to look at your device, because you'll be on the tablet answering this survey. You'll also be on your mobile device, and this is the time to catch up on evaluating the sessions you went to. Go back to the sessions on your device, and the ones that you didn't like, tell us. The ones you really like, tell us. We really take that seriously. We look at that. And so because your eyes won't be on me, your eyes will be on your screen, and you'll be doing what modern people do, which is sharing attention between your screen and what's going on around you. So go here now. It will ask you for your name. Don't tell us your name. Just skip that or make a name. But then you'll see some questions that will let you participate in the discussion. Our plenary speakers will tell us about how they've experienced policy engagement. We'll have them go one at a time. And after that, we'll have some engagement with you. Results of your survey, as well as live questions and answers. And we will be finishing 40 minutes from now, because we have some special announcements for upcoming items. So let me introduce our speakers. We'll have comments today from Professor Lise Rochaix, who is the professor at the Paris School of Economics at the University of Paris. She has been a member of the iHEA board. She is currently the chair of the European Health Economics Association, and she is very experienced in the topic of today. She has been called on by the French government in a number of different roles to help them access health economics knowledge. She's the scientific director of the Hospinomics chair, and she's on the board of the Agence Technique d'Information Hospitalière, which is the board in France that works on information and improvements in hospital information utilization. So Lisa will come and speak, and we'll also follow her up with the experience of Joe Kutzin. Joe, these are both iHEA members. We know them. I really don't need to introduce either of them, but Joe, well known to us. He is a local from Geneva. He's the coordinator of the health financing policy at WHO. He's had 30 years working in policy engagement, 20 years working at the WHO. Countries and health systems from around the world want Joe to help give them the best of our knowledge on healthcare financing. He's worked in Africa, Asia, the Caribbean, Europe, and well experienced in how our science can make changes happen. So we'll have first 10 minutes from Lisa, and then 10 minutes from Joe.
Can you hear me? Oh, yeah. Thank you for being here. Thank you, David, for inviting me to this wonderful conference, and thank you for the topic that you chose for this panel. And there was no way for me to say no. It was making health economics matter. That's what every day we do. And I think in this room, there's so many people who could say so much more than I will do, but I will stick to my 10 minutes. And I have come up with a slightly more complicated scenario than what was expected, as usual. I was supposed to talk to you about a true success and a failure, and I slightly changed that to 3 stories: a true success, a near miss, and I'm sure you know what near miss means in medicine, and a false failure. But the false failure, I'm not sure I'm going to get there because of time. So I will certainly get to the true success, because I couldn't help talk about this in view of all the presentations that we had, which referred to inequalities of opportunities. And so it reminded me of the work that we carried out with Eddie van Doorsler, Adam Wagstaff, Andrew Jones, and all the people who were in Brussels very early on to try and convince EU officials that there was mileage, back in '87 actually, in equity, at a time when, in fact, most of us thought that the equity issues were behind us because of the fast-growing welfare states. And so I just wanted to reflect on what has been collectively achieved over these numerous years, which I don't count. They're basically a change of perspective. And this conference really shows this change of perspective. And that's why I felt it was so important to raise this as a true success. I think equity is no longer considered as not measurable and therefore not accountable for. or worse, which has been often the case, only on the political agenda when there are presidential elections. So we've, as health economists, I think, we've shown that equality of access is important, but what we've shown, and this is what is currently debated, is that it's not enough and that we need to reach further heights. We need to look at equality of health, we need to look at equality of opportunities, and that this has been beautifully shown by the two guest lectures from Rochaix and Janet Curry. So, because I'm here to tell you about a success story, I'm certainly trying to work out what were the success factors. I saw 5 of them. I'm sure there's plenty others. The first thing is to start from the right policy question. We don't want to search, as we do now, for the perfectly exogenous shock that will make a perfectly irrelevant paper. I think we need, really, as we did, excuse my French, I'm a bit blunt. So I think what we need is really to do what we did in the EU project. We started by screening the official statements about equity at national level, and then we'll build the project from that. The second point is very early on to build strong networks. We needed to interact with policymakers at national, international level, with institutions such as OECD, WHO, ILO, and obviously Adam Wagstaff being at the World Bank, Eddie, Van Doorselaar working in strong connections with Southeast Asia, Andrew Jones with all the network from health economics. All this really allowed a wide percolation of the ideas behind the project. The third was to design readily adoptable policy toolkits. And I think in this respect, the equity project was one where a lot of effort was devoted in designing measurement toolkits, training sessions for users. It took a lot of time, but I think this is one of the important success factors. The fourth one is to prepare your own take-home message. And this is what Janet Curry said yesterday. I think you really have to be very specific about what you want to bring forward in a very synthetic way. And finally, be resilient. I think that's an obvious thing to say, but I think it takes a hell of a long time to change behaviors or perspective, which is, as I said, what I felt was the most important thing that's been achieved on equity by the Equity Project. So that was the true success story. We're doing okay for time. The story of a near miss now is a much more personal one, where I was working at the Treasury. I won't tell you when, and I was asked to produce this one page, obviously, on the savings from implementing out-of-pocket payments in primary care. I had all this background of technical work on estimating elasticities and so on. And I thought, how am I going to do a good job on this? So basically, I produced this rather short one-page summary, but I had a footnote that was very important to me because obviously the assumptions behind, the modeling were the ones that validated the results and showed that, according to the assumptions you made, there were some variations in the figures. And to my greatest surprise, the person who was taking us to the Prime Minister's office took a little pair of scissors and actually cut my beautiful footnote. So I understood that it's not just one page, it's one page with no footnotes. But I did take my revenge, because when I left the Treasury, I launched a large project on sort of micro-simulations and impacts on equity and feasibility, number of winners, number of losers, and by chance, a few years later, when it was all ready, I was called by Matignon, still the Prime Minister's office, to give my opinion on the topic, and I just came up with evidence. And I was so pleased to be able to highlight these, the results. And I must say, it's correlation, causality is not being inferred, but basically the reform was rejected. and it was a great relief. So what did I learn from that second story, which I called a near miss, because on the first occasion I was not ready, and it would have been a disaster if the reform had come along, because it was really a highly inegalitarian reform, implementing, as you can imagine, out-of-pocket payments in primary care, which is the last thing we need. And so the first thing I learned is that it's okay not to be ready for the first round, but you've got to be prepared for the second. So that's one thing I learned. So you have to have kind of hindsight and imagine what will come up in order to be ready for the second round, because it takes so long to produce evidence. The second one is that microsimulation is a wonderful way to avoid the single number trauma, which to me was a real trauma. Obviously, decision makers want to have, just how much am I going to save by implementing this reform? And to a scientific sort of academic person, it's really difficult to come up with just one number. So simulation is a way around it, because it will give the decision maker the possibility to press a button and to see the impact of different weights on different criteria. And so clearly that works very well. And the third thing I learned is that it is possible to systematically introduce into all these policy documents equity issues using microsimulations, and it will be understood. So that's in line with what we sort of discussed before. So, David, am I okay for the third story in 1 minute? So the third story is the false failure. When I was at HES, which is the French small sister equivalent of NICE in the UK, we had to work on growth hormones, and I set up a committee and the economic mandate, and my committee sort of came up with, after a full HTA report, a recommendation against reimbursing growth hormones. So in effect, disinvesting in growth hormones for many reasons. And unfortunately, the board of HES to which I belonged did not follow my committee recommendation. That's why I say it was, as you will say, false failure, because they felt that it was quite politically difficult to put forward a disinvestment strategies such as that one. But the recommendation, in effect, led to strong warnings as to whether or not a child should be given this kind of treatment, a very careful approach to the treatment of children, and also a recommendation as to important it was to have a change of perspective again on small size. And so in the end, it was a false failure, because obviously, I would have much preferred to have to see the committee's recommendation followed by the board of HES, but at the same time, it was one step into starting to be critical about growth hormones. So that's why I called it a false failure. And so, in conclusion, and I think to be exactly on time, I think we need to press on equity issues, as Richard Coxon, who is somewhere here, is doing with the Equipol group, by defining equity indicators, which will be used by the NHS, and I'm sure in the future more widely. We need, in effect, to come back to equity, maybe to consider the equity dimension as we do now for gender, by calling it gender mainstreaming. I think we could do just the same with equity mainstreaming, just making sure that in all the policy document recommendations, we systematically document the losers and the winners, the changes using all the equipment that we now have, the technical tools that we have for measuring equity. I think we can sort of somehow make sure that we use equity mainstreaming in what we produce. And I can't help sort of concluding that in so doing, we will be true to Alan Williams' words. What is the point of research if it is not to change the world? Thank you very much.
Thank you. And I see that you are...
Oh, it's me.
Very polite and looking at the speaker, and I hope you're still sharing your time between your phones and the speakers, because we have 10 more minutes to fill out the live poll and evaluate the material. Let me turn it over to Joe Kutzin, who will give us his stories of success and failure.
Thanks, David, and thanks, Lisa. I think I'm framing this as a story of trying to recover from embarrassment, because it's about the same experience at 2 points in time. And first of all, thanks very much for having me here. It has been really a great conference, and really enjoyed it. So some of you may know in 2000, I moved from Geneva to Kyrgyzstan in Central Asia, where I was the head of a program, both as a policy advisor to the Ministry of Health, but also to set up their first applied health policy research unit. And the first thing I did when I was there in late 2000 was had a chance for a meeting with the minister and asked about, what were his policy priorities. And in a sense, I was trying to elicit those in order to develop a research agenda. And they were about to implement, it was going to start in March of 2001, a major reform to deal with long-standing inefficiencies in the ex-Soviet health system that they inherited, and in particular, or among other things, the problem of informal payments. In principle, or in law, everything was meant to be free of charge, and I learned this expression, or I maybe made up this expression in seeing what would happen there and in other similar countries, which was the problem was that services were free until the point of use. And then at the point of use, it turned out often there were no supplies or you had to pay and so on. So they developed quite a comprehensive reform plan to address this, consolidating funding pools, moving from input-based budgets to output-based payment, and introducing a formal co-payment that was a fixed flat amount linked to the provider payment methods and explicit exemptions as well. Now, the interesting part from a research methodology perspective was the plan was in year one to start this in 2 of the country's 7 regions, then move to 2 more the following year, depending on how it went, and then reach the whole country. So as I'm hearing this, I'm thinking, this is great. We can think about a survey of patients discharged from the facilities, do this at the start of the period before it starts, and then 6 months later, another 6 months later, do this in all the regions, and then compare the reforming and non-reforming. So I had a beautiful methodology worked out, and so we began. And the reform was introduced in March. In late March, he called me in to ask about how it was going. And I said, it's great, we're just cleaning the baseline data now, and we'll have some results to know what the situation was like before this reform was introduced in terms of what people were paying. And by later, and I'm noticing he's getting a little bit uncomfortable as I'm saying all of this, and and then I conclude by saying, and by the end of the year or early next year, we'll see the follow-up results, and then we'll be able to say something. And he says, oh, that's nice, but I have to go to government next month and tell them how it's going. And I was thinking, oh yeah, I didn't think of that right away. And it was just, it's an obvious point that we deal with in terms of timing and relevance, in addition to methodology. So I was feeling very bad, but I had a solution, which was a colleague who was managing another program, who worked for the Swiss Red Cross, had been developing the first ever in that country, the first ever kind of rapid appraisal techniques, and eliciting through kind of systematic but qualitative assessment methods, perspectives on reforms and various things like this. So I went to see him, and he had a national team that was meeting, and I explained my problem to him, and I said, could you and your team do this? You wouldn't have to go to the whole country, just go to the 2 reforming regions, try to get some quick feedback. And he said, well, maybe, but I need some money. I said, what do you need? And he said, $700. I said, oh, okay, I can do that. I was able to take it out of my running cost budget. So next to the light bulbs and the toilet paper, there was $700 for a study, and there was all of these other things. So it turned out that study, which was well done, it was qualitative, but very systematic, it was good. It showed what was happening, got feedback, and essentially kept the reforms on track. So I was rescued by that. It was the best $700 I've ever spent. And so that was something. But of course, the reforms then continued, and they were continuing, and our more quantitative and perhaps more rigorous results came in next year. And when the time came for the decision about the rollout to 2 more regions, it turned out that the governors of those 2 regions were very much opposed to the rollout. And one of the things about informal payments in that setting is they tend to go up to the highest level. There's a system of appointments, and you have to generate revenues to essentially the flow of funds goes up to the governor and back. And one of those governors had been a minister of health before, so he knew this very well. But we were able to put together our results, and both with other development partners and with the reformers in the system. And in that second year, the findings, which were really showing that basically people were paying out of pocket actually a little less after this co-payment was introduced together with the other measures. The exemption system started functioning. And there were other aspects about reducing inefficiencies. So this was sufficiently convincing that they used that as one of the foundations for rolling out the reforms. Now, there was further work on this where we both had successes that led to other problems. One problem that we hadn't fully anticipated was how would the Ministry of Finance respond to the fact that money that they formally couldn't see because it was under the table and informal, it couldn't be seen, how would they respond to the fact that now there was an explicit and reported payment? And they responded predictably by cutting the budget in the next year. Okay, so in a sense, penalizing the gain in transparency that had been made by bringing the payments from under the table to over the table where they could be seen. And the response was, oh, you in the health sector have more money, so you don't need as much from us. And so, I mean, in the short run, that was a problem. In the longer run, it led to a very productive engagement between the health ministry and the finance ministry in order to get into things like rethinking how budgets are formed. Other aspects of this reform are, again, a shift from input-based budgeting to output-based payment. And that requires not just change in the health sector, but also getting into how you overall form budgets for the health sector. And so the whole public finance management alignment needed to come into that process as well. So it was ultimately, it led to, I think, some good results. As I said, this is now close to 20 years ago. So, I mean, things have moved on from there. But it was really part of a cycle that started to bring evidence routinely into the dialogue in a context where, in the past, the idea that implementation could be different from policy just was not really a consideration, right? Because that was not the world they were coming from. So this is really an important change. I think the lessons that I would take from this experience were a few. One is the importance of engaging policymakers early on in the process. I think that the idea of getting uptake of our work, certainly there has to be a strong demand for our work. And to some extent, if it's owned in a way by the policymakers, that's important. I think there's a balance that has to be struck between owning it and controlling it, right? So getting that balance between, and it's not that they say what the research should be, it's more about going from their policy priorities into a research agenda that has to be done by those who work technically on that, and then having some space for this. But if the research doesn't respond to their needs and their political concerns, it's very unlikely to have an impact. It doesn't mean that that's the only type of research that should be done. There's a lot of scope and role for independent academic research and other types of things. But in terms of, and probably my bias from where I've been sitting in WHO for so long, that really getting a sense of what the priorities are for the decision makers and how to inform next steps is really critical. I think another lesson was, of course, to do a much better job of understanding the policy cycle and the political situation that you're in. Because in a way, very good research that arrives too late is not good applied policy research, right? So it really has to be relevant in that. I think it's important as well to be persistent. Lise said to be resilient. which I think matters a lot. I found there and in other settings that evidence really does matter. It may not matter right away, or it may matter right away, but it's something that eventually comes around and becomes important in political discussions. And last, what I learned from the beginning, which is important, which is don't be afraid to ask for help. So with that, I'll say thanks very much.
See many open seats in the front and many uncomfortable people up in the back. This is the time to make noise, rustle around, come down to the front and be comfortable. I am going to now toggle over to our live poll results, and let's see. Here. Okay, so what are we looking at? That's good. That's what I wanted to see. That's question 2. And here's question... Okay. Great, so factors that improve utilization of health economics scholarship, and these you can still, it's not too late to raise your voice. First priority in our exercise was to have economists on advisory panels. Second, easy to understand policy briefs. Third, training policymakers. Fourth, wider use of MCDE. And more user-friendly league tables. What do you think of those results, panelists?
Well, in a sense, based on what I was just, I mean, obviously, none of us would be here if we couldn't say, well, you know, it depends. So, that's one. I guess, I mean, I think it's fine. It wasn't one of the choices, but basically from what I was saying, I was thinking of almost the reverse or the inverse of the first one, which is kind of economists invited to policy discussions or finding a way to engage with the decision makers. So this is, in a way, which is good, us providing having the opportunity to engage, which may be in the context of advisory panels, and maybe in the training part, that's fine. It would be policymakers, and of course, I think in practice, it's the senior civil servants or the senior advisors to the policymakers, which I think is often very critical as well in practice. But it's really that opportunity. It's what happens during the coffee breaks, I think, of the training sessions of the policymakers in economic decision-making that might matter in terms of that type of engagement.
Lisa?
For some reason, yeah, okay. I personally responded, and I put the wider use of multi-criteria decision models, which to me is micro-simulation models, higher up, because I could see, you know, as I tried to demonstrate how useful they were in getting decision makers to understand the trade-offs, knowing that training policy makers in economic decision making is a hell of a lot of work. So if we could make it simpler to them by using micro-simulations, we might get there quicker.
Great. Let me open up the comment box. I think it's going to open up here. And, oh, I know what I'm doing. I should need to go to next, right? Here goes. 44 surveys are underway, 101 done. So you guys are on it right now. And I go here, and it says next. There we go. So when pursuing reforms or better health outcomes, policymakers in my health system consider the relevant health economic scholarship. So we rarely, sometimes, mostly, and there was 8% frequently. This is exciting, and maybe during questions and answers, we want to hear from the 8%, because you have something that we want to know about. I believe you. I really do believe you, and please make that known. That's going to be really exciting. I would have said from the U.S. I would have been between rarely and sometimes. So what do you guys think what would you have expected here?
I think it just shows the variety around the room. In some ways, I'm thinking of the UK. You might have the frequently, because obviously there's a long tradition. In other countries, it might be the rarely. But sometimes it's reassuring, because it means we have a chance. But I would say most countries are in the sometimes. And I'm sure France is there too.
Yeah, I would just say that, at least in my sample, is probably biased, but for me it's been mostly, I would say. I mean, recently working in Kenya, and I mean, this is one of the most frequently questions. What has happened elsewhere? You know, what do we, you know, so there's an interest in that, because that's part of what the decision maker needs to sell the reforms. And my experience has been that they do care about that. But clearly it's very country specific type of thing. And as I said, part of the reason why we might be asked to go somewhere is there is that interest. So there's probably a selection bias going on in my experience.
Good. I'm going to turn the floor over to both of you now to react to what you've heard and seen. And if you had any other leftovers to your stories, please. Lise, do you have anything to react to?
I don't know if this is the right time to go for suggestions, because for the moment we've just been telling stories, but I think we need to have some suggestions as well. Is this the right time? Or is it a bit early?
This would be the time for that. We have roving microphones, and you have a box, so you don't even have to raise your hand and be recognized. You can text in and take the floor anytime you want. So please, let's call on you.
It's all coming up.
Okay, up here, Emma, and then you have one after Emma. We'll go to the gentleman there.
Hi there, it's Emma Frew from the University of Birmingham. I think my question would really be, in as much of a question as, do policymakers look at health economic scholarship, but it's how do they do that, and what mechanisms are they using to access that information? Because the work that I've done researching policymakers' views and getting their advice on what kind of health economics evidence they're looking for when designing policy is very much that they don't read academic journals, and what they look for is access to health economics colleagues, easy to read policy documents that are written literally on one side of page. So I guess it resonates with what Lisa was saying earlier, in that it isn't journal papers, and that we really need to think about the vehicles by which we're communicating our results, and also the outcomes that we're using as well, and whether those outcomes resonate with the outcomes that they are wanting us to focus on.
Reactions? And we'll take the microphone up the stairway. And other questions here. Can we hand the microphone up there next?
Hi, Gavin from South Africa. I think we just need to recognize that the majority of those in the policymaking sphere in the health sector, they're actually clinicians, they're doctors, they're medical practitioners. They don't have financial skills. Similarly, in private companies, your CEOs, often they're chartered accountants. So it's trying to get them to recognize and move away from clinical only focused on does it work, does it not? Because my response I get from policymakers are it works or it doesn't work. And cost is a concept that they're just not introduced to throughout their career.
Excellent. And we have a microphone up here.
Hi, my name is Mujahid. I have a question for all of us, actually. How many policymakers do we have in this room right now? So I think we should invite them to sessions like these. We have an awesome bunch of people that do great work that they don't know about, and this would be a good way to make them interact with us and know what we work on. So I think iHEA should invite more policymakers and, if possible, politicians to attend the sessions over here.
Excellent suggestion. I want to scroll down. I saw something come up here, and let me try to scroll to it. It was about the incentives of academics to actually do this kind of thing. And it was a notice that we kind of lacked incentives well, the academics do. Do you have any comments on that, maybe? Go ahead.
Share the questions because we want to be efficient. And so I'm happy to answer the question with clinicians, and you're answering the first question. And on clinicians, I think the challenge there is really to change their understanding of what it is that economists have to offer, because they think we're just there, as a support service. I'm sure this is, again, very blunt, but they tend to see us as a support service that's going to help them fulfill some of the requirements, notably at EU level, to have a cost effectiveness analysis, and they're just expecting the costs. We have so much to bring them in terms of research as opposed to just support services, that this is the way in which we've got to change the paradigm. And this is what I'm currently trying to do every day in my sort of research chair, is get clinicians to understand that we're doing research and we can bring in industrial organization, behavioral economics, and all this to bear, as many of you do with disease, for example, in HTA. But it's a hard one to get them to change their conception of what economics is really. Yes.
Well, just to say, I mean, I completely agree with the question about how, or the spirit, anyway, how do policymakers look at scholarship and the issues around how we communicate. That's really a critical issue of ensuring we find a way not just to talk to each other, but to reach those from outside of the discipline and so forth. And so the other thing, and sorry, I don't know if this might speak to one of these points, is that very often, at least in my own experience, we're in a position of trying to translate knowledge and evidence from one setting to another. And I believe that is more art than science. A lot of things can go wrong in terms of, taking the wrong lesson from one place, and we need to really kind of work out how to make that more systematic. We tend to get hung up on particular labels and said, okay, they've implemented this reform called this, and everyone says it's a success, so we can do it too. When we know from experience that whatever, let's say something called social health insurance, that it's just the details of implementation vary a lot from one place to another, and the lessons we want to take are those details, not the label. And that's really been a big challenge in the translation of knowledge from one setting to another. And managing, in a way, the policymakers' expectations and desires to have an answer with still giving them something useful, I think is important in that regard.
The issue of not having policymakers in the room. Well, it's a tough job to get policymakers to go away from the bench, and they're usually quite busy. So I think what we need is together sort of devise an online survey, and I'm sure they're going to be very happy to fill it in, provided we nag them to make sure that they do answer it. But it's a good point.
But I think we should try.
Absolutely.
Just on this point you raised here, because I think it's also important, and maybe because I'm not an academic, to put a challenge on this around the incentives. I mean, just as another story from the same place, the person who succeeded me in Kyrgyzstan also wanted to and eventually did succeed in having her PhD thesis approved on the issue of were those reforms in Kyrgyzstan pro-poor. But she had a very hard time convincing her advisors to agree to that topic because it was too broad. Right? And the issue was, and this was a PhD actually in health policy with a strong focus on economics. And it's really the challenge of accepting that policy is messy, And so, and a lot of what you need to describe to really understand what's happening, at least the way I write, makes the article too long for publication. Right? So, but those are the details that matter. And I think one of the bias is to have a very clean, and Lise said it at the beginning, right? What was that point about, you're looking for the perfectly exogenous shock to have a perfectly irrelevant paper, okay? Policy is messy, and we need to accept that, and find a way for our scholarship to engage in it. It may be, again, approaching things systematically and scientifically, but recognizing it's not a science. In that is as much an art as a science.
Let's go for another round of questions. I see one here in the front and in the second row, the third row, fourth row. Go ahead, Zabir.
Hi, everyone. This is an amazing session, and just to comment. First, I think when a researcher, either economist or the public health researcher, engage with policymakers or are actually taking an endeavor to do a research, it's also important when we are asking the question. And most of the time, we are involving the physician or the policymaker when the research is ongoing, because we need to get the data from this health facility or from other people. But we are not, most of the time, we are actually generating the question from us, because we are always thinking about that. We are not asking them what are the question you are interested in. And that is also important, and which level. Of course, most of the time, even if we are asking them the question, we are asking either a top-level ministry official that what you're interested in. We are not going on the managerial level at the district. So that's one thing. The other thing I was, when Dr. Bishai was talking about incentive of the academics, is also we have to think about incentive of the policymaker. And most of the time, I don't want to be cynic, but health of the population, I don't know if that is in the top incentive of the policymaker. There are other kind of incentives. So how to actually modify the information or modify the message to align with their incentive, and what is the understanding their incentive, that is also most important. Thank you.
Great, and then row 4. And who was next after row 4? Anybody else? Let me see. Over here, I think on the left, but there, okay. Go ahead.
Aidan Hollis, University of Calgary. Just in my limited experience in influencing policy, I found that it was really important to understand the perspectives of the winners and losers, and to really figure that out first, not to proceed in some kind of pure academic way, but actually to really dig down and find out, you know, what do people in industry think? What about people in whatever distribution or whatever it is? They all have different perspectives, and if you don't appreciate those things, then you're going to be undermined by them. So understanding those things at least seems like a minimum prerequisite to really having policymakers listen to you as an informed person.
Great, that goes along with getting the policy context right. We'll go with Jack, and then I see another one here in row 3. Go ahead, Jack.
Thank you. Jack Needleman, University of California, Los Angeles. Fascinating discussion. I want to just reinforce a couple of points I heard, and then I actually want to ask a question of you. Joe, your comment about what happened elsewhere is a classic. When I spent 17 years in consulting, and that's often the first question that people want to know. People are looking for stories about what effect their policy is going to have in an effort to define how to do it. And I think an awful lot of translation needs to be done in that regard, in terms of being able to tell a story about the research, which gets me to my question, which is, we have very, very few cases where one study is the definitive study that answers all the questions about what effect will this policy have. We have lots of research that looks at specific pieces, and it needs to be integrated up. And if we're talking about academic incentives, there isn't necessarily the incentive to, the incentive is to get published with your specific narrow focus in the best journal you can. Not a lot of incentive to try to be an integrative force, but also not a lot of forums for doing that. The press often plays that role, but I'm wondering, from your experience, where are the other integrating activities that help define what we know about things, and what role should academic economists be playing in filtering and supporting the integrating activities for translating what we've learned into the implications for policy?
All right, so we're closing down to the end of our time, so I'm going to ask to take your question either on the box or come up after, and I'll turn it over to the panelists to wrap us up. Go ahead, Lisa.
Something which I share completely. I've seen recently, at least in France, decision-making being increasingly based on questions of external validity. They don't want, the super study in a very specific area that they know nothing about in terms of scaling up. So even decision makers have understood the importance of scaling up when funding a reform, and so they want, in effect, what we call external validity. And so one of the proposals that we've been thinking about beyond doing the survey on decision makers was that we might support special interest groups, for example, within iHEA and possibly in collaboration with you here, where we can try to pool the experience we have, for example, in prevention. There's been some very interesting sort of presentation in different interventions in prevention to try and think, first of all, on the basis of existing results, whether we can do some pooling, and this special interest group could be aimed at giving information on the external validity. And we could even think ahead and think of ways in which we could carry out research ex ante that would, in effect, sort of mimic a kind of meta-analysis. So a special interest group might sort of be one that could be the outcome of this discussion based on your question.
Yeah, just, on a few of the things quickly. The question about the incentives for policymakers. I think the main thing, and this goes back to the story I told, is that policymakers need things fast, right? And particularly elected policymakers. And that I think has some, again, one of the things I took from that experience and try to take elsewhere, countries doing a reform, is not that qualitative methods are better than quantitative, but you need qualitative to start now, so you can get some answers now. Not to divert from the longer term, but basically you need to provide some results quickly. And even as you do more rigorous things that give you more long-lasting, because that will still be useful. But if you don't deal with that short term, you don't get to the long term. I think the question about the different perspectives of winners and losers is also important, at least from my experience in a lot of the, in a number of countries where new health insurance agencies have been put under long-standing, say, Social Security and pension funds. The perspectives of the people, and this was certainly my experience in the former Soviet countries, people who had been running pensions, they expressed, for example, that this health insurance thing is really unfair because some poor farmer in the countryside is entitled to the same thing that I am, even though I put in much more money, right? And, you can't say that somebody's values are wrong in a sense. So the issue is thinking about, okay, what does that mean in terms of how we communicate? Because many of these countries have gone through this phase of saying that wouldn't individual savings accounts be better than pooling? And so in a way, needing to respond more on efficiency grounds than on equity grounds might be part of taking in that issue. And then I think just on this last point, Jack's question about, what are those things that, that integrate. For me, it's about saying that the research can't be about saying, proving that something works. We hear a lot of this about whether or not PBF works or social health insurance works. There's so much variation within those instruments that we have to get at the underlying pieces, that the conditions that enable something to work or not. And that is more of what's translatable. So there's a number of different reforms under the label of health insurance recently. The things that have enabled something to work has been how general budget revenues are being used and transferred. We also have, for example, a recent study from our European region looking at 24 countries' studies of financial protection and how different policies on patient cost sharing have been associated with the results. And there's a very clear pattern that when basically it's defined as coinsurance, as percentages, you get very poor results in terms of financial protection, whereas either a fixed copayment or an annual cap or something works or tends to work better. The message in translating that, when I think of this in other settings, is it kind of depends on the administrative capacity. For example, doing an annual cap is really difficult in a context where you have a weak information system. But any country ought to be able to do a fixed amount with keeping the core principle in mind that what people should be paying shouldn't depend on how sick they are. right? And if you can just take that principle and see how do I translate that into practice, I think those are the kinds of things we have to try and bring into practice.
Great. Lise, do you want to make a comment? Okay, all right. So what I'll do is I will take your responses and we'll post them on the iHEA website so you can all make access to them. I want to thank our panelists for an excellent set of comments, and thank you for your participation. Thank you. And for the next few minutes, we just want to make you aware of some coming attractions, and I want Tor Iverson to come up and tell us about an opportunity that's coming up soon. Let's see. Can you find Tor's presentation?
Yeah, it seems to be working now. So on behalf of the local organizing committee, I would like to invite you to the European Health Economics Association 2020 conference in Oslo, 7th to 10th of July next year. The title of the conference is Health Economics for Sustainable Welfare Systems. There will be 4 plenary speakers, so here are their names and preliminary titles. So François Bourguignon from Paris School of Economics about health as a dimension of social inequality. Sherry Gleed from New York University, what can Europe learn from US health reform? Matthias Kiefmann from University of Hamburg, the future financing of European welfare states, the case of healthcare. And last but not least, iHEA President Lise Rochaix, Paris School of Economics, can we do away with theory in health economics? There will be the conference evening event is planned at the National Opera House. And here are some practicalities of important. Oslo has a convenient location with the direct air connection with all major European cities, with distance 25 minutes with train from the airport to the city center. And there will be hotels and other types of accommodation in a variety of prices. So the abstract submission is expected to open in November and close in late January. So to all of you, please, you are very welcome to Oslo next year.
Thank you. And let me invite John Atta up, and can someone queue up his video? John Atta is the director of the Center for Health Economics at Cape Town University. I want you to get to know his face because I want you to see his face again in Cape Town in 2 years. Go ahead, John. Do you need a mic? With a
Good afternoon, everyone. We want to really welcome you to Africa. We call Africa the home of everyone. So we're welcoming you back home to where we all started from. And you're coming home to Cape Town. And if you understand geography, Cape Town is at the bottom. Okay? Cape Town is really holding the home we have. So it's the home of all homes that you're coming to. And we promise you that coming to Cape Town is something different. You have a touch of Africa, and it's something you will live with, remembering that you want to come back to Cape Town. So I don't want to preempt what you're going to meet. But what I want to tell you is what you're going to meet is more than whatever you're going to hear at the moment. So please sit back relax, and watch.
Thank you, Danke, Enko Zikaku. On behalf of the Health Economics Unit at the University of Cape Town and our African partners, we would like to express gratitude to the International Health Economics Association for selecting Cape Town as a host city for the next World Congress in 2021. We are humbled by your choice and honored that you have put your trust in us to deliver an exciting and exceptional conference. We will strive in every way to bring you an excellent program with an African touch, with offerings that are attractive to an international audience.
The University of Cape Town is an inclusive and engaged, research-intensive African university that inspires creativity through outstanding achievements in learning, discovery, and citizenship, advancing a more equitable and sustainable social order and influencing the global higher education landscape. We are the leading university on the African continent and one of the first to initiate health economics research and teaching with the establishment of the Health Economics Unit in 1990.
Hosting the next iHEA Congress in Africa will help to raise awareness about the importance of health economics research and capacity development for population health and well-being. Will elicit commitment from African players to institutionalize it, and will position Africa as an important contributor to the global health economics agenda. Recently voted the world's leading festival and events destination, Cape Town has plenty to offer visitors, and we are confident that it is a city that you'll be excited to visit. We look forward to welcoming you to Cape Town in 2021.
Thank you, John. And yes, I think we're all looking forward to Cape Town and to seeing you again. So thanks for coming to Basel. Thanks for a great week. We have a short reception for you outside, and we'll see you in Cape Town.